This video, I would like to explain burns and its treatment. The burns or destruction of the skin. It occurs superficial or even deep at the skin. Causes of burns include mainly fire, hot liquids, example hot water, steam, soup, hot soup, and hot metallic objects, caustic chemicals, example acid or alkali, electricity. So these are the causes of burns. In the case of children, scald burns with the hot liquids is the most common form of burn injury in the children, followed by flame burns. In the case of child abuse, should be considered when a child presents with glove or stocking, burns of hands and feet, single area deep burn on the trunk, buttocks or back, and small area thickness of burns, mainly for example cigarette burns. So we need to consider the child abuse in the case of burn injury. That is also a cause of burns, especially in the children. We may categorize the burns into three based on the degree of burn, based on the total body surface area burned. So it can be classified into three as first degree burn, second degree burn, third degree burn. Usually first degree burn produce a redness of the skin and they heal without scarring. So this first degree of burn is usually called as minor burns, having the burn in the total body surface area less than 10% in adults, less than 5% in young aged people, and less than 2% of full thickness. So this will be considered as minor burns. In the case of second degree burns, cause destruction of deeper structure within the skin, resulting in blistering. So this will be called as moderate burns, having the total body surface area around 10 to 20% in adults, 5 to 10% in young aged people, 2 to 5% of full thickness. So this will be called as moderate burns. When you see the third degree of burns, destroy the full thickness of the skin, leaving an open area. So this is called severe burns, having the total body surface area greater than 20% in adults and greater than 10% in young aged people, and greater than 5% of full thickness. In the case of emergency measure, so what are the emergency measure has to be taken when the burn occurs? First of all, we need to remove the clothing. So that is a first emergency measure should be taken after the burn occurred. Then remove or cut away jewelries, particularly rings and bracelets, to prevent constriction and vascular compromise during the edema phase in the first 24 to 72 hours post-burn. Ensure and maintain an adequate airway and provide humidified oxygen by mask or endotracheal tube based on the patient's condition. Then start the IV ringer lactates or normal saline immediately after the burn occurred. 10 to 20 ml per kg per hour. Even the percentage of burn is not yet calculated. Insert the nasogastric tube and avoid oral fluids in children with burns greater than 15% of body surface area to prevent aspiration as they have developed illness. Destruction of gastrointestinal tract. Insert Foley catheter to monitor urine output in all children who record IV fluid recovery. In the case of fluid resuscitation, fluid recovery, the fluid recovery part is important when the burn occurs since they lost fluid content in the body. So the patient must be rehydrated with ringer lactate or normal saline 4 ml per kg per percentage body surface area burned. In the case, half of the fluid is given over the first 8 hours calculated from the time of onset of the injury. Half should be given first 8 hours from the time of onset of the injury. The remaining half is given at an even rate over next 16 hours. So first 24 hours you need to divide half for first 8 hours, then remaining half should be given the next 16 hours. The rate of infusion is adjusted according to the patient's response to the therapy. Adequate fluid recovery is reflected by vital signs, acid-base balance, mental status, and adequate urine output 1 ml per kg per hour. During the second 24-hour, patients to begin reabsorb edema fluid and to diurese. So we need to half of the first day fluid requirement is needed as ringer lactate in 5% dextrose. So you may add DNS 5% instead of plain ringer lactate or normal saline. So we are adding, instead of normal saline, we are adding dextrose in the next 22 hours of the patient. Later on, oral supplementation may be started after 48 hours of post-burn. In the case of wound management, we will see one by one. First, we will see the minor burn. So the minor burn can be treated in outpatient setting. The wound is debrid of all loose skin, so the dead skin can be removed with the debridement. The debridement is the important main way of removing or preventing the infection. Normally, blisters are better not excised in the first degree burn, and open wound management is preferred in the case of minor burn. All dirt is removed by cleaning with a mild soap and irrigating with the isotonic saline solution. The irrigation also a better option for preventing the infection. So we need to irrigate with the isotonic solution for removing the dirt and preventing the infection. The wound is then covered with silver sulfadiazine or put gentian violet and properly dressed. So the first degree of wound, that means minor, should be dressed, and dressing evaluation are performed 24 to 48 hours after injury. Silver sulfadiazine cream 1% applied daily with sterile applicator for the treatment and prophylaxis of infection in burn wounds. Or you may go with Fusidic acid, thin film of 2% cream applied to skin 3 to 4 times daily. In the case of moderate and severe wound management, moderate and severe burns, we may manage with applying local antibiotic, that means topical antibiotic or Vaseline coated dressing. So normally oral antibiotics will be administered in the case of stabilized infection. We may continue for at least 5 days until all signs of infection is subsidized. In the case of extensive burns, we may go with penicillin intravenously. Adults 4 millions per unit, in children 1.5 million per unit. Or you may go with penicillin 1.2 million per unit intramuscularly every 24 hours. Further, we may go with antibiotic treatment is indicated if any supra-infections, if any secondary or opportunistic infection is there, you may go with further antibiotic treatment. In case of moderate or severe burn injuries, there might be some additional support measures for the patient. So you may give additional support for stress-induced ulcer. For preventing the stress-induced ulcer, you may go with the first-line treatment, cimetidine, 20 mg to 40 mg intramuscular, or you may go with slow IV every 4 to 6 hours. This is the first-line treatment for severe and moderate burn injuries for preventing stress ulcer. Or you can go with oral omeprazole 20 mg 4 times a day for 4 weeks for duodenal ulcer, 8 weeks for gastric ulcer. If there is any GI bleeding, it's better to go with pantoprazole intravenously. Or if it is a minor, not that much stress-induced ulcer, you may go with the adsorbents like magnesium trisilicate plus aluminum hydroxide. Chewable tablets 500 mg plus 250 mg chewable tablet 1 hour before and 3 hours after meals and 1 in the bedtime. So this is for the prevention of stress ulcer. In the other case, tetanus toxoid should be administered if you have to incur further immunization against Clostridium tetani. So we may administer as a booster or primary immunization intramuscularly 0.5 ml. For the pain management, you can go with first line paracetamol 500 to 1000 mg orally 4 to 6 times a day. Alternatives, if there is a pain is severe, you may go with morphine injections 10 to 20 mg intramuscular or subcutaneously. Or you can administer pethidine intramuscularly. For adults, 100 mg 4 hourly as required. In children, 0.2 to 2 mg per kg 4 hourly as required. Thank you.